As also Martina was mentioning to you, we will just briefly go through what were the steps to arrive here today. So what we did in the past months, and then we will start with our exercise. So just for you, if you weren't also in the other workshops and you are for the first time here today, over the past months, we have been working together to better understand the regulatory landscape that surrounds health tech innovation in transitional care. We started by collecting evidence through a survey that we distributed to living labs working in healthcare. Which allowed us to start to identify the main regulatory barriers and enabling factors that are experienced in the living labs. Building on these findings, we then organized our first workshop where we explored the concept of regulatory learning. We discussed the main challenges affecting transitional care more in general. And then we reflected on the first policy recommendations ideas. Then we had the opportunity to present these preliminary findings and the first also emerging policy recommendations during the annual regulatory learning session with the Joint Research Center. So it was really a great idea to start also putting our efforts in the hands of policy makers. Today's workshop represents the next steps in this journey and also one of the last, actually. We would like to build on everything that we learned so far. And we want to learn your experience. In fact, while the other workshop and the other works that we did were more focused on identifying the regulatory barriers that were affecting transitional care more in general. Today, we would like to take a more targeted approach, and we want to focus on 3 different contexts to collect a more concrete experience and example from your living labs. So the use cases that we will use today are the first one, the hospital discharge management and monitoring. This use case focuses on ensuring a safe and seamless transition of patients from the hospital to the next stage of care. So, for example, rehabilitation, home care, or nursing homes. The digital solutions that are often used during this setting are electronic health records, health information exchange, medication management applications, and telehealth services. And these technologies enable secure information sharing, continuity of care, and effective also post-discharge follow-up. So in the exercise that we will do also after, we will analyze also what are the regulatory barriers in the case of this use case, and what maybe if you worked in something related to these use cases and the next that I'm gonna show affected your work. So the use case number 2 is remote monitoring and home-based care optimization. It focuses on enabling continuous remote monitoring and optimizing also home-based care through secure communication and data sharing between the patient and the doctor. So also here, the digital solutions include remote monitoring devices, mobile health applications, telehealth services, and also artificial intelligence for early risk detection. These technologies are really important because they enable real-time health monitoring, also timely interventions where needed, and also an improved patient engagement, and also a more effective care coordination. The last use case is inclusive technologies for aging and chronic care. This use case focuses on supporting older adults and people that have chronic illness through accessible and inclusive digital technologies that can promote independent living and active involvement of family caregivers. So also here, the technologies that are used are voice assistants, cognitive assistive technologies, family engagement platforms, accessible and user-friendly digital interfaces. These technologies enable greater independence, improve also the communication between the patients, the caregivers, and healthcare providers, and more inclusive person-centered care. So based on these 3 use cases, we are going to start our exercise. And Despina, I will leave also the floor to you. If you want to explain it a little bit, I will share the Miro board in the meantime.
Thank you, Francesca. So we're going to work on Miro. Francesca will share the link soon. If you don't have experience with using the Miro, feel free also to just speak or write it on the chat or ask for any help. We would like to discuss also as we start to figure out and put their post-it. So we would like to be interactive and not only focused on the Miro part. And what we will try to do, as Francesca explained, we will try to focalize and bring the focus to the specific use cases one at a time so that we find what are the barriers that we have faced as living labs from our experience of bringing our experiences. And then we will try to find crazy and new and innovative solutions, not only on what we have done, but what we would like also to do. And of course, then we will try to summarize all of that. And then we will move to the second and the third. And just to say that these use cases, they are different, but they are not exclusive. So, of course, hospital discharge management doesn't mean that it does not include the aging and older adults. Or, of course, the older adults do not include the hospital discharge management. We just tried to split the transitional care pathway into specific cases so that we have a more precise focus to talk about. So I have seen that you have already entered the Miro board. Does anyone has a problem entering?
All good on my side. I'm in.
Okay, great. So let's start with the hospital discharge management and monitoring, the use case one that is shown also in the screen here. And let's focus on step one. We will take about 5 minutes to work on that. So we would like to take 1 or 2 minutes to think of cases and examples that you have dealt with a hospital discharge management or monitoring case and what barriers you have found. If you don't have an exact case in mind, you can link to other experience that you have with other cases and try to think how this can be reflected in a hospital environment and specifically how the doctors do the discharge. Feel free to take sticky notes from the left part and place it there. Or also, as I said, you can open your mic and speak or write it in the comments.
And sorry to interrupt, if when you are writing the post-it, if you can also write your name or the living lab that you're talking for, it would be really useful also for us later to follow up.
And also if we can zoom the Miro board, we keep the post-it all the same size, otherwise we will not have enough space. So we just zoom the Miro and we keep the post-it as they are, if possible.
Okay, there are already nice experiences, but let's take another 1 or 2 minutes to let people write down. I already see an emerging theme of data sharing, data responsibility, data requirements. So what are the requirements? Who can we share the data with? Who is responsible for sharing this data? How actually they can be shared and become interoperable? Fear from the families. Procurement and reimbursement regulations. Who have wrote this? Maybe you want to comment, because I think this is something also different from data perspective. So
Yep, that's a good one. The real barrier isn't just the data itself, it's who owns the handoff when the patient leaves hospital. If nobody's clearly responsible, the whole discharge process gets fuzzy fast.
So it links back to responsibility, who takes decisions.
Actually, Despina, I wrote that. Yeah,
Okay.
it's about, hi, hello from my side. It's about who takes responsibility, especially in public hospitals, on how some digital technologies or some new devices can be incorporated in an already existing environment, actually.
Okay, great. That's, I think, very important and not clear from regulatory perspective, and it also differs from healthcare setting to healthcare setting. Okay, so the time went quickly. So I think that there are a lot of nice ideas, mainly focused on data, how we deal with data, security, understanding, who takes responsibility of its data and data sharing. So let's start also going into ideal solutions. If you want, we can focus first on this big aspect that has arisen on data. So if the main problem of data security, the fear of the patient, if you were able to do anything, actually, I don't know, if you don't like GDPR, cancel GDPR, or have a new law in the European Union, whatever you can think about, and you have an unlimited amount of money, what would you actually like to do? So what will be your ideal solution for data security, data responsibility? What would you like to have to solve that? And also, of course, you can start thinking of all the other things that have been written here. I'm just focusing on data because I see it arising a lot in the post-its. Make information governance easier to apply for. So how would you do that? I don't know who wrote this, but maybe if you want to comment on what is your idea on how exactly this can be done easier, like what is
Yes.
it? What do you mean?
Yeah, so thank you. Yeah, I'm Jeanette Hughes. So I'm from Digital Health and Care Innovation Centre in Scotland, and we run a range of living lab projects. We have about 150 projects in our portfolio. What we tend to find is information governance can hold up the process, and data sharing governance. I suppose what we would solution to that could possibly quicker processes, and
Right, that's
also being very clear about liability, because data sharing can often be the barrier, as in one organisation is trying to share with another, and it's a liability that gets is the barrier to actually moving it forward quick enough. So we in Scotland think that maybe the person holding the data and giving consent to share would actually alleviate that barrier or accelerate it, so that we could actually move forward a wee bit quicker. So I don't know if that covers what that section was trying to achieve.
Yeah, we actually are looking for any ideas. So like who the person is and what they can do with their data is in the sender. Okay, great. Clear explanations, I see. Easy to navigate document that is kept up to date. So this goes again with clear language, and I think that goes for the patients, the doctors, or both. I think it's good tech living lab. So if you want to comment on that.
Hi, I'm Emma from Good Tech Living Lab. I think for both, but mainly for patients. Yeah.
So mainly to for their fear of sharing their data, so that you can beat that fear.
Yeah.
Okay, nice. Okay, and maybe also we can take 1 or 2 minutes for this, because like we can also think of solutions that Living Lab can bring, because these are like very good solutions, of course, but they can be brought, some of them, by other organizations. So what is the specific point and value that Living Labs can bring on that? And most of you, if not all of you, are working on Living Labs. So what is these specific value and ideal solution that the Living Labs could bring in that barriers? And again, we're thinking in the case of hospitals, and how we do this discharge management, and linking that with the real world barriers that we have identified, like data security, reimbursement models, etc. So if you want to say or write down what is this specific. Yes, please, Janet.
Yeah, so I suppose again, if you're looking for quicker discharge, a lot of the time it's because of communications between the hospital and outside the hospital, to get them discharged. For example, if they have more needs that need to be accommodated by what we would call social care in the UK, they need to transfer the data and they need to find resources to set that up. So again, one of our solutions, we think in the long term, is if the person holds that data, that discharge would be quicker because they could share the data immediately with whoever needs to look after them within the community. So I think that's maybe quite visionary thinking, but we are an innovation centre, and we have been testing that with some living labs in the north of Scotland, because if the patient owns the data sharing challenges are reduced because I consent, to take my data from the hospital, if they give me the information, into the community and share that data within the community, probably quicker than the hospital getting in touch with the municipality to say this person has to be looked after in the community, and I'm going to try and share the data. And then all the communication that goes alongside that transaction. So I'll write that down, but it probably needs that explanation that I've just verbalized to go around that post-it, because it is quite a different way of thinking about data sharing.
Yeah, it's a very interesting idea. It might add some technological issues, maybe of how you have your data, like in a format that is like very easily accessible and manageable by the institution that you can go from hospital, either it's a hospital or a rehabilitation center, but like keeping everything that is your data and taking it with you, I think it's a very nice idea. Good, great. So any other thoughts? And we can also move like slowly to the final discussion, which is actually this what we would like to focus on. What are the things that Living Labs can bring, the ideal solutions, and what we would like to ask to change. So let's say that if we talk to the European Commission directly and we say, okay, we want this to make our life easier because Living Labs can do that, what would this be? So what will you say at the end? And having in mind also these solutions that have been mentioned. And I see here I posted that is also linked with this C that says create province country consent framework. Consent. Okay, so this goes with ethics, right? Ethics consent. I don't know who wrote that. Okay, I see predefined as a solution, predefined processes which are pre-accepted and pre-verified by authorities. Teemu, so can you elaborate on this and what living labs can maybe do for that?
So the idea was in a way that whether it's a small change to, let's say, a project or process that what we've done previously, we always have to still do the whole, the process again, even though it's a, let's say, minor change from the what we are doing. So what I was thinking about that, it would be much more effective in a way that if we have a, let's say, common things that what we do, co-creation workshop, or the whatever testing for the device, it would be kind of more easily get accepted if we follow, let's say, a certain basic template or whatever, and it has been verified that this process is okay. And then that was the kind of thing that I think in many times we do, the overlapping work a lot, and it's kind of replicated not only for us but also all the ethical boards or the administration who is thinking about, do we accept this project or not. So that's the idea.
That is very interesting, and also something that came out from the previous workshop that we have done is that the restrictions and the risks are not the same if we are testing a low TRL and a high TRL. So if you're like testing an idea, a concept creation in a living lab setting, it doesn't have to be the same amount of regulations and restrictions as if you're running a full clinical trial of, like, let's say, a medical product. So maybe this balance also could be linked with what you said, Teemu.
Yes, definitely, yeah. And for example, when doing this kind of the discussion that was the thing that what we were testing, was it the medical devices or not, and always at least now I think the suggestion is always that if you have even slight possibility that your device will be a medical device, you should be following that process already from the very beginning, because later on in the process they will be asking at what has been done before, in a way. And if you have not followed the medical device process, then it's the thing. But it's kind of a controversy comparing to what you said just previously, that if I run a concept testing for the the device or something like that, so why the hell I would be doing all the the extra work for that, because it's increased the cost of the development as well and delays the process. So it's kind of a controversy in that suggestion.
Yeah, so like maybe more flexible regulations, or more clear in some cases, also depending on the development level and advanced level of the technology. Okay, so we have some more minutes, so I will give you 1 or 2 minutes again to think. If you are talking to a commissioner, a person that is, I don't know, producing the regulations for the European Union, what you will ask for? Yes, please, Janet.
Yeah, so I think we touched on technology readiness, or certainly you mentioned technology readiness. I suppose in Scotland, in our living labs, we talk probably more about the service readiness in light with regulations. And what we mean by that is how is it going to be used in is the regulations, well, firstly, think about it early, which I think somebody else said, and I certainly wrote down. But secondly, they're not proportionate. So as you say, if it's a non-clinical service and you're putting a technical device in, for example, SMS, you're wanting to get people out of hospital, you're going to put SMS into the workflow. that doesn't really need regulations. But if you're going to send the person home with a heart monitor, and that heart monitor is going to have to do 24/7 monitoring, and that data's got to get back into the hospital, into a dashboard, etc., then obviously the regulations have to be much higher because it's critical care. So I think it's a proportionality of what the service pathway looks like, and it might be a combination of technologies, not just one, which sometimes can be difficult to manage if it's actually a suite of technologies that you're bundling up to get them out of hospital. So I don't really know how I would write that down in a post-it note, but hopefully if this has been recorded, AI can make some more sense out of it. But yeah.
Yeah, I also depend on AI because the discussion is very interesting and you cannot capture everything in post-its. But yeah, that's this service versus TRL readiness is also like really important, because it's not only if the technology is ready, but how you integrate that in the different services. It can be a technology that in one setting is medical and in another setting it's just well-being. Okay. Good. So any final comments or proposals on what we should include in the policy recommendations for this use case? I remind you again that this discharge management and monitoring in the hospital. So what do you do to monitor people in the hospital and help them as they are being discharged? Oh, I see a nice one from Sarah. So Sarah, if you also want to explain a bit.
Yeah, so a lot of what the solutions that we heard today is around giving ownership of data and access to that data. And so those from whom we're collecting it should be around the table, which are represented by our community and patient organizations. And we certainly do that in Canada regularly, but it ends up being in very sporadic way as opposed to from the beginning to the end of the policy planning. So finding a mechanism to make sure they're always consulted through the whole process.
And I think also living labs can play the role of this regulatory, not sandboxes, but regulatory learning environments in which the regulators can be involved with the people and the community before they bring out any new regulations to see if these are accepted and how. Okay, I think we can move to the second use case. So we are now moving a bit outside the very strict clinical settings. So it's about remote monitoring, home-based care. So after the person has been discharged from a clinical care facility, either hospital, rehabilitation, or even maybe some outpatient monitoring. What are the barriers that you have encountered in terms of regulations when we are speaking about remote monitoring and home-based care? Some can be similar, of course, but let's try to get out of the clinical case the strictly clinical environment and think about the home. And if you have any like particular project that you have run, you can also share with us and guide us through the barriers that you have found. So does anyone have any example, any project that you have run in home care or a remote monitoring of people?
I could give one example. This is a very long time ago. Laura used to have this kind of an pairing TV kind of a solution. So basically that means that, you know, that it was integrated as a part of the normal television, and then, you know, you could have like sessions where the, you know, the multiple patients or people at the home could be together in a way, and there was like some kind of, for example, some exercises or stuff like that. And then I remember there was some issues that they were talking about that, you know, because in the home there might be other people as well over there, and then they would be showing on the TV or something like that, and there were some issues, if I remember correctly, on that one. And that was basically related that, you know, you don't have a strict control that who was seen in from the camera in that sense. But we haven't been running that anymore many years. It was like an old technology back in 2012 or something like that, or 2010 or. But that was, I remember that was one of the issues. And I think it's similar thing whether you would be using now the new technology, because it was about that who was shown on the camera.
So again, very much related to security, data, like who the data belongs to and what you can analyze if it's not the person that you're monitoring. Yes, please, Janet, you can also share.
Yeah, I've tried to write it down in the post-it note as well, but we were involved in a living lab in Glasgow in Scotland, and it was for COPD patients. So when they were getting discharged from the hospital, they would get a pack of devices, wearables, and they would use their own mobile phone. They would collect the data daily, like oxygen levels, mobility data, just generally how they felt. And that data daily would go into the hospital environment, and that hospital would have a dashboard. The dashboard would then use AI to segment the most critical patients in the community. And then they would do an intervention in the community where the nurse would then go out and maybe administer antibiotics. So they were using the technology between the patient's home and the hospital, and they were also activating the community nurse to then visit, and that was reducing hospital admissions for COPD patients by 52%. So that all worked quite nicely, and actually the patients quite liked having that ability to, I suppose, communicate with their consultants on how they were doing on a daily basis. So that's an example from Scotland.
And you mentioned that there was AI that were taking some decisions and doing some suggestions. So were there any regulatory issues with that AI that you have to face?
Yeah, obviously it had to go through, it was a research and development project, so it wasn't going into live. It was semi-live because it was COVID times. So there was regulations that had to be considered. The AI was really just stratifying the data, bringing the alerts to the top of the dashboard. So yeah, I can probably find out more about how they went about the regulations around that. But yeah, it was a good example of accelerated hospital discharge because you could keep an eye on patients in their own home and in the community, kind of home-based care.
Nice. I see other things arising. Digital literacy of patient and family can be a barrier. And also I see accidental data or missing data. So if you want to comment on what is accidental, what do you mean by accidental data? I don't know.
For example, was that the example about the video feed that I was saying that it's like a
Okay, yeah.
yeah. And also the other one related to that is that whenever you're collecting the data, you will also get the possibility to indirectly identification of personal data or the persons who are involved in a way. Meaning that if you have, let's say, you know the location and you know what they do and whatever, and you can to combine multiple things in order to identify the persons, even you don't know who are the persons. If you're tracking, for example, movement or something like that.
And also maybe also accidental findings that can be an ethical issue. Okay. Missing data, low motivation. So these are barriers for sure. These solutions sometimes are isolated from the whole healthcare intelligence. So integration and interoperability probably. Okay, so this, the way I see it, there is no common theme arising, but there are a lot of issues like literacy, how we make sure that the data are not missing, are not accidental. Let's try again to think of solutions and in a way that these are linked also with policy and regulations. So what the regulations could help us, for example, achieve more motivation for the patients or use better their data and solve the barriers that we have talked about. And also like a very nice point of discussion is this AI that has arisen also from our previous discussion because it's something very new. So what you can think also what do you expect from regulations on AI to look like? I see someone wrote policies that recognize wearable and home monitoring as part of official medical records. So I don't know who wrote that and if you want to comment.
Hello, again, it's me, Kostadina from Thesahar. So basically, just to give a motivation and to see a value for the patients that are using wearable devices or home monitoring devices that, for example, if they measure their blood pressure every day and they see a pattern or some different values, that they can have it digitally or as an official record for when they visit the doctor or when they go into a hospital. In this way, they see that the doctor always also trusts the measurements, but also the patient sees value in them.
Thank you, Costandina. And I see a +1 here. So if you agree, if you want to add something, the one that. And I see faster way to validate and use new devices. Neapolis, so I think Alex, if you want to comment on your experience from that.
Yeah, well, at the end is a little bit of mix of everything that we have been talking about. Um, we struggle, as I think that many of us, when we want to use some new devices in order to have it validated from from the hospitals and some more healthcare organizations. They always say, yeah, we need the certificate, we need to pass this kind of steps and so on and so on. And furthermore, in Catalonia, there is a huge public foundation is just focused on validating new devices and new AI algorithms and so on. So at the end of the day, from the day that we discovered some interesting new device for whatever reason, the blood pressure, cognitive assessment, I don't mind, until we can use it for clinical trials and have a and saying that this is a validated data, we are talking about not less than a year. So make almost impossible for us to do some kind of really fast-paced test.
So maybe also have the rules of what it considered validated, like for each stage probably. And as we were talking before, for TRL level readiness and also service readiness, that this means validated. For concept, this means validated. I don't know, just like thinking out loud as well.
This can be a great idea, because this long way, it's not just based on the TRL of the product. Because at the end of the day, in order to have this clinical approval, once again from Catalonia government, you need to be in a high levels of TRL, not something before or beyond 6 TRL 6. It's completely out of the scope. So even this can make us to do another question. How difficult is to test some prototypes, which, for example, for me, it's really complicated. It's really complicated because for me, the regulation is not, it's not based on trying new things trying and dismissing, for example, good or bad ideas in a, how can I say, secure data environment, but in a really in an agile way or a fast way. I don't know. I don't know if I express myself good enough.
Yeah, for me it makes sense, and like as I see also this sandbox validated IT infrastructure, I'm wondering, and I would like to ask you if we as living labs can serve as an environment that we can do this first validation without so strict regulations, so that we allow this technology to go to the next level.
Indeed. Work as a living sandbox lab can, could be a great idea that can help us to solve lots of these issues, but also for the government can allow them to understand many of the things that they are not understanding because of their big procedures.
Great. So let's spend 2-3 minutes, and then we go to the final use case. If you can write down in a form of a wish or recommendation in this final discussion of what we have talked about, what would you wish to see as a living lab to be done? So maybe you can also frame it in a way like, I wish this to be done, so that we can move forward and that we can break these regulatory barriers that exist. And as I said, you can also say things that sound not feasible, so don't be afraid to dream big. If you don't like GDPR, AI Act, Data Act, whatever, you can also say it. So I see. I wait because Sarah, I see a very interesting one that you are writing also if you want to tell us about it.
Yeah, sometimes a lot of the organizations we bring into the Living Lab are a lot of time passes and confusion, and sometimes initiatives start and stop because the decision making around which technologies and if they're safe and if they could be rolled out, there's many steps, as we all know, into getting there. So if the Living Lab can be like the one go-to place to answer that question of, is the technology safe and ethical and can be rolled out, to give them a framework to follow and an environment to have those discussions with all of the people that need to be around the table represented. So sometimes they'll come to the Living Lab, but they'll come too late or at a certain part of the process, or so if it could be more consistent so that there are not too many parallel initiatives happening, I think that would be most effective overall for having an impact on patient care more rapidly in terms of use of technology. So I'm trying to say that, but I haven't had enough coffee to write it fast enough. So
That's really interesting, and that will be like very important, and I think also have benefits in the patient care, and maybe also accelerate the way of new devices being validated more quickly and reaching the patient more effectively and efficiently. And it's very important for all use cases. Living labs are seen as a safe place to test and trust the results, so we can scale and deliver evidence for home care. That's really, really nice. Yes, please, Janet.
Yeah, for art, which we find certainly in Scotland and the UK, which is probably all our living labs are testing and developing evidence along with partners, whether they be academics or industry. And even if there is good innovations and good evidence from a policy government perspective, and maybe this can go up to the EU, there isn't enough innovation transfer budget. And what I mean by that is, how do you take research and development testing into business as usual? And I don't think that's just Scotland, because I travel enough and do keynote speeches everywhere in the world, that I know that is like, that's the end game barrier. So it doesn't matter how good all this evidence is and all the innovations and all the technologies, if we don't have somewhere to land, then it's experience for everybody, I'm sure. But where's the impact? So I think there's something about financial support for hospitals, community-based institutions, to actually move it into business as usual. And I don't mean that they should just use the budget that they get for keeping the lights on in the hospital. It needs to be a defined innovation transfer budget where they actually are incentivized to actually move things from testing and usual. Obviously, with the caveat that the evidence is safe, secure, you know, everything that goes with it, and the regulations are met. So I don't know if this is the appropriate conversation workshop to have that discussion, but yeah, it should probably be noted maybe at a higher level.
Yeah, and from our experience, this is also like very evident in healthcare because there is also this gap in reimbursement models, who pays for what. When you go to public domain, things are always more complicated than the private. You're talking about lives and not like crops, which is like for the soil example. So everything becomes much more complicated. So yeah, this like support of this gap between what your results are and the results of the Living Lab and bringing them to market. Very nice, very interesting. Okay, I think we start getting tired, so let's go quickly and discuss a bit on the last use case, which is focused on aging and chronic care. And here, of course, again, is not exclusive, so it includes some aspects that we have discussed previously of home care, hospital care. But here we would also want to focus more on people that maybe have some accessibility issues, that might be more marginalized in some cases, or have lower independence. So they have these barriers to consider as well. So again, if someone has worked with that populations and have some experience, please feel free to share with the group. Oh, sorry, Janet, I was reading your post-it note and I couldn't see your hand.
Yeah, I think probably to bring it to life, yeah, we did a living lab in the north of Scotland, and it was to do with carers, because what we tend to find that health and care obviously look after people to a certain extent, but a lot of the time as aging populations happen, or people with problematic long-term conditions, it's the carer that actually is doing the data input, possibly, and also doing the data communication. And sometimes we find, and this is what we found, if you look at regulations, the regulations, the privacy policy, the consent is mostly because you should be typing your own data in, and that proxy isn't actually even it. You can't tick the box saying, are you completing this for your father who has dementia? So there's a human aspect that we have to then just work around the system, because we're like, my dad can't do it, so I'm going to type it in as if he is typing it in. But there's something about the regulations realizing that they need to give the option of, is this for someone else? So I don't know, but we found that in the carers living lab, because the carers were doing a lot of that administration burden.
Yeah, and how important it is to involve the carers actually to all this process.
Yeah, so we co-designed it, and actually we ended up coming up with an innovation that allowed the person to have a personal data store, but the personal data store to be able to be completed by their circle of care. And that was documented and authorised and approved. And then that circle of care could then send data to organisations if they had to interact, which then allowed them to tell their story, like 70% of their story, before they reached that service, rather than going 100% back to the beginning. This is my dad. He's got dementia. He's had it for 5 years. So we found that from a carer, that's what they want. Regulations don't really allow for it, because it's not really set up that way. data is usually between one organization to another or one person to an organization. So yeah.
And that's already a solution that you have used and maybe have worked.
It is a solution. I'll put a post-it just to say the personal data store was used in that instance, just to remind you.
Great. Great. So also I see a good tech lab. So if you want to share like your experience, if you have worked with such cases and what barriers you have faced.
Yeah, we used it as use case. The technology that we had in our living lab, not really using it because it was a bit complicated for us, and that the fact that I wrote there was from the users sorry we had some activities with some people and we presented this idea and that this was their concerns, like how much data the family can see or can access, or the price, maybe it's too pricey for elderly people.
And I see also in your post-it note the legal framework for family and carers, which like links back to also what Janet discussed. Great. And ABN technology, ensuring data security requirements, ensuring data are not linked with other sensitive data and only saved for a short period of time. Yeah, the things that we mentioned in the consent, but nobody knows if we are doing at the end. Nice. So let's focus a bit, like time is passing, but if you have any ideas or if you have faced somehow these gaps on how carers can be put in the loop and how they can, if there are any legal frameworks on giving authorizing data from carers for the patients, and especially as we are talking for elderly patients. So if there are any ideas there, or also for this high price, if there are any regulations that can deal with that. And of course, the data security, and especially if we're talking for vulnerable populations. So you can take 1 or 2 minutes to think about it as well. So Sarah, do you have any solutions that you used? Maybe also, I don't know, in Brilliant, or how this data security is being handled, or
Yeah, so the way that we've managed it is it's under data sharing agreements. So it's allowing the industry partner that we're working with, which is Greybox, to have data sharing agreements across institutions where the patient is receiving care. So all the use cases we talked about today, a given patient may be in one of those use cases along the pathway, along their trajectory at different times. So the best way we've been able to do it is data sharing between us, research evaluation, and between the institutions. So with our healthcare organization, we're mapping out the legislation or the policies that would allow them to do this on a larger scale if it wasn't under the premise of a research project or a living lab collaboration. And what we're seeing, this is kind of what I meant with parallel initiatives. So they might have a hospital at home initiative going on in parallel to our transition of care project. So they will have independent agreements with other companies, and then we have to repeat those agreements. So this is kind of what I meant about one of the solutions, which is a shared framework for data sharing, where solutions or technologies can sign on to be part of that. Is if they've met the minimum requirements of the province to be operating within the province.
That is really nice, because also like clinicians and hospital managers might be very tired of like reviewing and redoing and re-signing documents that they're very similar to one another.
That's a big challenge we have. Yeah, they keep asking us, is this a system that will be in place in a month from now in a week? And do I have to download this into another system or repeat it in another system? I don't know about other places, but for us, we still struggle with the shifting from paper to tech. So in many instances, we still need to print everything and put it in the patient chart for legal reasons. That's a big challenge. It takes a lot of time from the clinical team. We're using technology to increase efficiencies and be able to spend more time in care. But when they still have to do an administrative step like print, it sounds like a small thing, but it takes time. And from the technology adapting to that printing to look exactly like it needs to in the chart poses some challenges sometimes.
That's very also very, very important. And it's something that I think healthcare has been left behind because other domains are like moving faster. And it makes sense. I mean, you have to do with lives, and any mistake can cause a big problem. But still, I mean, we have advanced a lot the technology in order not to need to print everything out again and again.
Yeah.
Good. Okay, so does anyone want to comment on anything more particular that we should take into account? Because also like these recommendations that we will give to the European Commission can also guide the new funding framework for the Commission. So we would really like to reflect on what the Living Labs need. Yes, Janet, please.
Yeah, it's just one final comment. So with the care example that I gave, where we were using, obviously under research and development in the Living Lab, we were using the personal data store to hold the patient's information, and they had consent. When we actually came to test it with the municipality and the NHS board, because the patient owned that data, information governance was signed off pretty quickly, like within days, where we have applications sometimes with NHS sitting for 6 months because they just don't have enough resource to get through the information governance applications. So I suppose it's that balance between if the patient has that data, information governance becomes easier to do research and development. So I suppose I'm always talking about research and development and trying to get it into the system, but I think that's a really important point. And yeah, I'd be interested to know across the living labs around the world how long it's taken things like information governance to get through, signed and activated. Maybe it's just us in the UK, but it's definitely a blocker or a delay. It's not exactly a barrier because it eventually does get overcome, but by the time it gets overcome, things have moved on.
Yeah, I don't know if anyone wants to add for their countries, but in Greece, it's like the same barrier. Mainly when we're talking about public clinical care institutions. When we are talking about home monitoring, things might be easier because if we are at research and development and not like actually selling products, it might be a bit easier. But yeah, I don't know. In other countries, how is the case? Is it lengthy? Is it?
I can say I'll say for Quebec because healthcare in Canada is provincial. So, but I see the other provinces. The short answer is yes. Between having the agreements in place and, like you said, the way they're interpreted and implemented is different across even just health regions within the province. And then by the time it's figured out and some places are running smoothly, then there's another change in legislation or in the way things are running. And so it feels like starting over. So very, very similar in that sense of how long it takes.
Janet, you're muted.
Apologies. I suppose there's another conversation around regulations, information governance, that it's not the technology, as we've touched on, sometimes it's the skills. So we don't have enough people in the system that understands even what the risk could be. So the risk might be low, but they may be escalated to high because they don't understand. So they don't want the liability to sign it off, and the delay causes problems somewhere else. So I think the skills, not in digital, but the skills in understanding the implications of digital from a legal, data, liability perspective, especially when you start bringing in AI, is it's usually out with the capability that you have within an organization. And if you do have it, you're probably very unique, I would suggest.
That is really interesting and important. So also literacy and digital, I don't know, digital literacy for people that are also taking decisions and not putting liability and strict rules above all.
Yeah, and it's not the digital. So say you're a lawyer in a NHS board or a municipality, most of the time you're not buying digital products that could harm somebody. So it's a completely different liability than if you're buying mobile phones for the staff or desktop computers, or, it's a completely different mindset, and the risks associated with it are very you need skills to understand what it is you're getting involved in. So those skills, the softer skills, are not probably as apparent as they need to be.
Great. So also our time is up. The discussion was very interesting. The meetup will be also open. So if you think of any other crazy solutions, I don't know, this night that you will be relaxing at your house. If you come up with any crazy ideas, you can write them down, and we will make sure to take everything into account, and of course the recording and all the discussion that is made, so that we try to come up with some practical recommendations for these three topics. So Francesca, back to you for the closing.
Yes, thank you. I will share right away the presentation. Second, just to show you the next steps. So basically, after today's meeting, we're going to draft the policy recommendations with all your inputs. And yes, of course, feel free to continue using the Miro board, adding your examples. And you have my email and also ours, the one of Despina and of Martina. So if you have examples that you want to share, links or everything, feel free to share them with us. And we will be having a workshop, not a workshop, yes, a validation workshop in September, just to go through all together to the policy recommendations that we drafted and to see if there is something that needs to be changed, some last minute thing that needs to be added, just to have your really final approval. And yes, so this is our last step. It will be our last step. But Despina, I leave
Thanks, Francesca.
again.
Really rich discussion.
Thank you so much. Despina, I leave the floor to you because I know that you have also other few things to say.
Yes, just to thank you all again for the involvement in this discussion. We hope that the recommendations that we will give to the Commission will also be taken into account on the next steps that they are going to take in the healthcare, and hopefully also for the next funding program that Enol is also advocating mainly. And also just to tell you that, of course, you can be involved in the general discussion about living labs in healthcare through our working group. So after this meeting, Francesca can also reshare with you the link if you're not already members to register and follow us and discuss with us. And of course, we will all see you in the Open Living Lab Days, which is the main event of Living Labs, which will be held in Brussels this year. Brussels and Antwerp, actually, Belgium. And we will have a session there again in healthcare and living labs. So we would love to see you all there.
Thank you. Thank you very much, Despina. Thank you, Francesca. Bye. Thank you all.
Thank you.
Thank you
Bye-bye.
all.
Thank you.
Bye.
Bye-bye.
Thank you. Bye.